I wanted to just finish up with a little bit of what we were trying to talk about on Monday about increased intracranial pressure. On slide 53, it talks about drug therapy, and so some of the drug therapy is aimed at reducing intracranial edema. So we have mannitol, which causes really an osmotic effect and helps to reduce fluid in the brain. We do need to be concerned about electrolytes in the vascular space: sodium, potassium, chloride, and magnesium and phos, all those. And also we need to be concerned about the osmolality or osmolarity of the serum. And then hypertonic saline also helps to move water out of the cells and into the blood. So we need to measure, obviously, since we're giving hypertonic, sodium levels. And there's a limit to how high we want to let sodium go. Other drugs, which aren't used quite as much anymore, but are corticosteroids. We also, in the treatment of these patients, are going to do what we call GI prophylaxis with H2 blockers, like famotidine, or proton pump inhibitors like Protonix. We could also be treating seizures with anti-seizure medication. We could also treat temperature with antipyretics or external cooling devices. We can use sedatives like benzos, propofol. It's not a benzo, but propofol is a sedative. We can use analgesia, fentanyl, morphine, barbiturates. We'll have a look at collaborative care, including nutritional therapy, on slide 56. So treating AT's neurologic status postoperatively, we continue to do our subjective data, continue to monitor and assess our level of consciousness, continuing to record our Glasgow Coma scale, which consists of the eye-opening, best verbal, and best motor. Pupils, slide 59 kind of gives you pupils equal and react normally, pupils react to light slowly, and we could briskly or sluggish. Dilated pupil could point to nerve compression, cranial nerve 3. Bilateral dilated fixed pupils are ominous. Pinpoint pupils could represent damage to the pons or drugs to cranial nerves, eye movements, corneal reflexes, oculocephalic reflex, which is doll's eyes reflex, oculovestibular caloric stimulation, where we put cold into the ears. Motor strength, like squeezing hands, moving feet, dorsi and plantar flexion. So vital signs, of course, abnormal patterns of respiration. Noted on slide 62 are some classic respiratory patterns. So what would be some priority nursing diagnoses for AT? Well, nursing diagnosis: decreased intracranial adaptive capacity, risk for ineffective cerebral tissue perfusion, risk for disuse syndrome. Overall goals to maintain a patent airway, intracranial pressure within the normal limits, normal fluid and electrolyte balance, and prevent complications secondary to immobility and decrease the level of consciousness. Respiratory-wise, we want to maintain a patent airway, elevate the head of the bed 35 to 40 degrees, suctioning if needed, or good oral care, minimize abdominal distension, so a bowel regimen. We use drugs like Colace, Senna, Doctosate, and others. Lactulose, polyethylene glycol, mag citrate. There's so many to get people going. Monitor blood gases for effective ventilatory maneuvers. Pain and anxiety, so opioids, intravenous propofols. Presidex is another one. It's expensive. Neuromuscular blocking agents like succinylcholine, which is more short-acting, but We use things like Nimbex, which called cisatracurium, benzodiazepines like midazolam, Ativan, and fluid and electrolyte balance. Monitor IV fluids, so strict I's and O's. Electrolytes daily, monitoring for DI or SIADH, which is either going to be a lot of fluid peed out or no fluid. Monitor and minimize increases in intracranial pressure. So what nursing measures can you use to prevent further increases in AT's ICP? Well, do all those things that we just noted. Increasing the head of the bed, preventing extreme flexure of the neck, turn slowly, avoid coughing, straining, Valsalva, things like that. So AT continues to be somewhat confused even after evacuation of a subdural hematoma. What nursing interventions would be appropriate to prevent further injury? Minimize complications of immobility, protection from self-injury, like be careful about using restraints and sedatives, maintain seizure precautions, usually a quiet, non-stimulating environment, and psychologic considerations. Expected outcomes would be, of course, to maintain your ICP low and make sure they have adequate cerebral perfusion pressure. Okay, I think that's it. I'll be back later with another recording, probably on spinal cord injury.